welcome to today's Lunch and Learn presentation, Live a Quality Life with Alzheimer's. I'm Peggy Schmidt, and it's my privilege as North Kansas City Hospital's President and CEO to welcome you today. Thank you so much for joining us. Alzheimer's disease is one of the leading causes of death in Clay and Platte counties and one of the top 10 causes of death in the United States. Unfortunately, as of today, there is no way to prevent, cure, or even slow its progression. However, we are optimistic. Ongoing research is giving us hope for new, more effective treatment and options, hopefully one day for a cure. North Kansas City Hospital is home to 7 specially trained, board-certified Veritas Health neurologists who diagnose and treat neurological conditions such as Alzheimer's disease. We are very fortunate to have one of those wonderful neurologists with us today, Dr. Jeffrey Thornton. He will help share the latest diagnosis and treatment methods for Alzheimer's disease. Dr. Thornton received his medical degree from the University of Oklahoma College of Medicine, and he completed his residency in neurology at the University of Nebraska Medical Center. Immediately following Dr. Thornton's presentation, we'll hear from Stephanie Ramirez, one of our speech and language pathologists. So now, please join me in welcoming Dr. Thornton.
Well, it is truly a pleasure and a privilege to be here with you today talking about something that has touched many lives that we come into contact with, family, friends, and we see that Alzheimer's is a different diagnosis than other medical conditions because it affects fundamentally who we are, our memories, our reality, and that's different than other organ systems. So what I would like to do today is to fill you in on as much of the new and what I would say exciting research that's going on in not only the diagnosis but also the treatment of Alzheimer's disease. Just to cite a personal example, as a young man, I witnessed my own grandfather develop early symptoms of Parkinson's disease, many of which can be a little subtle and hard to pin down. We don't know, is this normal aging? Is this something more significant? And those are things that are best sorted out by your primary care physician. Bring up your concerns, and then your primary care physician can help determine, is this something that needs to be brought to the attention of a neurologist in consultation? So let me get started today. We've got a number of slides, some of which I feel are going to be more relevant than others, and I will move past some quickly. We'll have time for questions towards the end. So if there's any difficulty understanding me or hearing me, please just let me know. But I understand we will have some time for questions at the end. So Alzheimer's disease, as we want to address it today, we're going to cover again the impact, the causes, the diagnosis, the prevention, the treatment, and exciting research. So I'm going to save some information towards the end that I think will be so helpful for us when we look at a disease state that seems dark right now, that there's nothing exciting on the horizon. Well, I hope to challenge that because I see potentially down the road some breakthroughs on the horizon. None yet, but some excitement, and I'll get to that towards the end. So many of us saw and really cherished one of our former presidents, Ronald Reagan, and I think this is a very apt quote about what he went through. And I just feel like it also is something that many of us see in a loved one who's experiencing early symptoms of dementia. 6 months ago, he stopped recognizing me. Now I'm having trouble recognizing him. Again, back to the fundamental changes Alzheimer's wreaks on our personality, our memory, our consciousness, who we are. It is the sixth leading cause of death in the United States. This is a very big diagnosis, and I think it's going to become even more problematic because we're getting better at saving people's lives from heart disease, from cancer, and we're all living longer. And as we do that, Alzheimer's becomes a looming issue. And our hope is that these numbers start to decrease, but as of 2010, which are some of the more recent accurate numbers we've got, there are 5.3 million people in the U.S. living with Alzheimer's disease. Over 100,000 people in Missouri. I tend to think that's an underestimate, but again, the most valid numbers we have. It does have a significant impact here in the Northland, so this is not something that is everywhere else in the country. On the coast, it is very much a heartland of America problem. And Clay and Platte County, right in the areas we call home, it is increasingly problematic. And I'd say one of the leading causes for consultation that I see in clinic is my father, my husband, my wife is having problems remembering what he told me. Is this significant, Dr. Thornton, and how do we get some answers and prepare for the future and maybe even get some treatment? So this is a big cause of monetary expenditure too. In other words, it costs us as Americans almost $150 billion annually, and that's in everything from lost wages to care that we provide directly to patients. This is not a disease that affects the patient alone. This is profoundly impactful on families. Caregiver burden can be enormous. And I always try to address caregiver burden because a lot of times it's not just the family in the exam room who are feeling this along with the patient, it's their friends, it's other relatives. It's a very difficult disease. So, again, just to reiterate how this is going to become more prevalent as we treat other chronic diseases, we live longer. Alzheimer's disease is typically a disease of our later years. So therefore, if you have a higher age population, you have more dementia. And I'm going to really try to sort out now the difference between, and this is one of the most common questions I get, Dr. Thornton, what is dementia and what is Alzheimer's? So dementia is a set of symptoms that is very nonspecific. It's not a diagnosis, it's really symptoms. Alzheimer's is the #1 cause of dementia. I hope that clarifies. People sometimes find those terms to be ambiguous or synonymous, and they're really not. So lots of things can cause dementia, including head injury, just ask our NFL players. And in addition to that, frontotemporal dementia, Parkinson's disease, and stroke are all ways to get to dementia. But as you are about to see, Alzheimer's is by far one of the leading causes of dementia. But dementia is a nonspecific term. And this defines it as a decline of cognitive abilities in comparison to a previous level of performance, causing impairment of functional abilities. In other words, we have to bear in mind where somebody started. Was this a PhD quantum physicist, or was this a laborer? And we look to see that difference. Has there been a decline? But also, is it affecting their activities of daily living? And the most important thing is this, does not mean that somebody came into the emergency room with a urinary tract infection and couldn't recognize their son or their wife acutely. That's different. We call that delirium. We've all maybe seen a loved one post-operatively or with another disease state who becomes disoriented in the hospital, and that's delirium, which is different than dementia. Dementia is gradual, it's insidious, it's progressive, and it can creep up very slowly. Delirium just comes on like a thief in the night. So again, back to its gradual progressive nature, memory is one of the most common things that it affects early on. I want to say, as a caveat, I've seen numerous patients who have come in with nothing but language problems. In other words, gradual problems with speaking, reading, expressing themselves, and forming coherent sentences. So it's not always memory. Dementia can affect every aspect of our functioning, and that includes orientation, concentration, complex task performance. But I would say that until late in the disease, there's not a lot of motor function abnormalities. There are several genetic forms and susceptibility genes, but I want to really focus on this not being something written in stone. If mom or dad had it, it does not mean that there is something written in the stars that you're going to get Alzheimer's disease, period. And what I hope to do by the end of our talk today is offer you some real concrete, scientifically proven ways of lessening the likelihood you ever develop it. Something we can all take home, some lifestyle changes that are very meaningful to you in avoiding memory problems and Alzheimer's disease as we age. So genetic forms do exist, but even with the majority of those, they are not an oracle predicting the future of your memory. Causes. Again, back to dementia being a really, for lack of a better word, a trash can diagnosis. There are lots of things that cause dementia, which is a very non-specific term. And this talks about Alzheimer's disease, vascular dementia, diffuse Lewy body disease, and various others, including chronic traumatic encephalopathy, which our soldiers are returning with. As we thought of our soldiers yesterday, Veterans Day, I think of many of our Iraqi veterans and Afghanistan veterans coming home with chronic traumatic brain injuries that will increase the risk for developing dementia down the road. So just to point out over here, a very normal, healthy appearing brain. Language and memory are two symptoms I just brought up. This is the area of the brain they reside in. And notice the full appearance of the gray matter and the white matter internally compared to a diseased brain over here. We call this atrophy. Atrophy is where little neurons have gone out on vacation and have just not ever returned home. So you can see a big volume loss here, and the medical term for that is atrophy, and we see that on MRI, but it's non-specific. In other words, we can see it with normal aging too, which brings me to a very clinically important point, and that is MRIs do not diagnose Alzheimer's disease. Nobody can look at your images on MRI and say, there's the Alzheimer's disease. It is a combination of a history, a physical exam, a mental status exam, imaging labs, and a review of records, and that's what neurologists do for a living. So there's really not a good diagnostic test that's 100% sensitive or specific for Alzheimer's disease. It's a multimodal approach of, frankly, talking to the patient and family, first and foremost. Finding out what that original baseline is with language and memory, and talking about where the changes are. And ruling out the other things that can mimic it. Brain tumor, stroke, bleeding being some. What causes Alzheimer's disease? That's an excellent question, and frankly, if I could tell you definitively there was a single cause of Alzheimer's disease, I would win a Nobel Prize. You're not going to see me sitting here with a gold medal around my neck anytime soon. Some of the leading minds in the world work on this daily for a living. And we do know that there is a combination of environment, aging, genetics. I've heard a researcher tell me one time, we feel like, to use an analogy, the Alzheimer's disease is caused by a combination of environment and genetics. And think of it as genetics loads the gun, environment pulls the trigger. It's not one or the other. It could be identical twins. And we're asking ourselves the question, why would one identical twin get Alzheimer's disease and another not? They have the same genes. If you've sequenced every gene in their body, they're identical. Something in their environment had to have triggered it. And there's some really exciting clues that are on the horizon now that can help us with that. So take-home messages. There's many causes. The process starts long before the symptoms begin. And I'm going to focus on that. In fact, I will repeat it. You will not wake up on one day and have Alzheimer's disease. Alzheimer's being really a clinical diagnosis, but what you would have is 30 years before that, the buildup of little tiny changes in the nerve cells of your brain, which we're going to look at visually here in just a moment, that you can see decades before a clinical diagnosis of Alzheimer's is made. So when does Alzheimer's start? The answer is years and decades before you show symptoms. How do we make that diagnosis? I've already alluded to a few things. The history, talking to the patient, the old lost art of actually talking to your patient, listening to them. Lab tests. Is there B12 deficiency? Is there thyroid disease? Is there a brain tumor or stroke? That's not Alzheimer's disease. Let's fix the problem. Let's get to the bottom of things to get things better. So, we have to do our homework. And that's really what the first visit with a neurologist is for, to do our homework, find out what is the likelihood that there's something else causing this entirely. Maybe they're on a medicine that is making them artificially appear less cognitively able than they are. So, I'm going to skip over some of these because I don't think they tell us a lot. This is looking at cerebrospinal fluid, and there's some markers in cerebrospinal fluid, which is the little clear fluid that bathes our brain and keeps it in its nice, warm, happy hot tub all day long. We can very easily pull some of that fluid out, send it to the Mayo Clinic, look at a couple markers. Does it tell us a lot more than what we already know? No. So I don't find it very clinically relevant to put a 4-inch needle in somebody's back and remove spinal fluid unless it's beneficial. And right now, that's not a routine part of my clinical practice. PET-CT. PET is an acronym for positron emission tomography. Think of it as a special CAT scan, looking at how energetic certain parts of the brain are. And you can see here that this is a very normal blue, being a highly metabolically active brain. The glucose, which is the energy source of the brain 90% of the time, in this brain, in this brain, and this brain, are all dramatically impaired, and that's shown in red. So, again, these images are helpful, they're part of the puzzle, but by no means are they a diagnosis. So again, just more demonstration of what the images should look like, a normal healthy brain. But I would also look at, see those dark areas too, lots of volume loss. The neurons are already leaving the building, right there in some of these. So controls in Alzheimer's. So we call that PET-CT, and that is something we do at North Kansas City Hospital. And we do find it to be clinically relevant sometimes whenever we need more information. Well, people always say, gosh, Dr. Thornton, we've got a lot of non-specific things we could do. What would give you a 100% answer? And the answer is, frankly, pathology. We could look at brain tissue on a microscope and say, yes, there is indeed changes of Alzheimer's disease. Do we do that? Absolutely not, because nobody wants to have a brain biopsy. They're dangerous. And it does not help us to an extent that warrants the risk to the patient. So, pathologically, a brain biopsy could tell you the answer quickly. And this is what we would see with Alzheimer's disease, and this is frankly what Dr. Alzheimer saw 110 plus years ago. This is called amyloid. Amyloid is just a fancy word for protein. A little protein deposition there. And see how that looks like a tangle? These are neurofibrillary tangles of amyloid, which is those plaques building up, being toxic to the brain. What we have is a protein that is normally taken out of the brain. Like you take the garbage out of your own house, neurons, like every cell in your body, is producing waste material that is not being adequately cleared, and it starts to ball up or gum up in these amyloid plaques. They've looked at ways of getting rid of these with antibodies and things like that, albeit not successfully. So this is a potential research opportunity. By the time you see a lot of these, we're a little late to do something about them. The best thing to do is to prevent these plaques and tangles from ever building up. And I say that to the end of my talk because that's something I think we can all take away. What can I do different starting today to help prevent my brain from ever showing these signs? So again, plaques and tangles, these are little nerve cells we call neurons. We have billions of them, and we need every single one of them. The whole adage that we only use 10% of our brain is just an old adage. It has absolutely no truth to it. You need every brain cell. So this is what the tangles look in a kind of cartoon schematic. And this is just a plaque like we saw there on a real piece of brain tissue on the slide. You can see how this affects all those intricate connections that tell our brain our memories, our ability to speak and express our love for our family members and verbalize our thoughts and remember what we had for breakfast this morning. Those tangles affect every part of that. And again, back to age and prevalence, should be no surprise that we have more dementia as we get older, and a lot more 85 and 90-year-old patients than we used to have. We've got a president who's gravely ill today, Carter, who we're all thinking about having brain surgery. He's 95. He's the oldest living president of all time. We're all living older, which is a wonderful thing. We want to make sure that we're not just physically healthy, we're cognitively healthy. Certain genes here, I'm going to move past this quickly, do put you at risk. These can be checked for, including on 23andMe and on various other websites. They can look at your Alzheimer's risk. Do not overvalue that. They are interesting, but the question is, do they really tell me that, hey, I'm going to get Alzheimer's disease? Absolutely not. They might show a little bit of increased risk. So, we think the following cascade of things occur. Starting up here with these proteins. I know this looks really fancy with some of these symbols, but basically this is just a schematic documenting what I've already told you. We end up with these proteins that our body is trying to clear, and frankly is unable to do so, and that leads to brain cell death, which is what causes Alzheimer's disease. Treatment, what can we do? Excellent question, and I think one of the most relevant things today that we can discuss and take home, and we're going to get to that. So we've talked about how the disease starts from early, let's say 40s and 50s, these plaques are already building up. 25 years later, when you're 75 years old, is when you are all of a sudden having your spouse bring you in by the ear, typically, go in and talk to this neurologist, there's something wrong with your memory. And I'll be frank, the majority of my patients don't have a lot of deep self-insight into their symptoms, and it is usually a loved one that is saying, you need to be evaluated. So we see a lot of other causes for memory issues early on where patients do have a lot of self-insight, but that's usually not Alzheimer's disease. It could be anything from medicines to depression, a head injury, things like that. Including B12 deficiency or thyroid disease can cause memory problems. But I tend to see in my clinical practice loved ones saying, please come in and talk to the neurologist. There's something going on, we need some answers. And a lot of times there's not that insight. But there is where you start to see more symptoms out, let's say 75, 80. We all saw that graph increasing well into the 80s. So here's maybe just to use that age range, the 50 to 75 year range, where maybe you aren't going to write a Pulitzer Prize winning novel like you would have at age 30, but you're still doing well. Your career's flourishing. You remember all your grandkids' names and birthdays. But it's really right here where you're asking the same questions over and over. You're not remembering your daily activities. You are struggling with those activities, daily living, so it's beginning to affect you. And there's a purgatory range we call mild cognitive impairment before there's definitive Alzheimer's disease. And out here, there's frank dementia, which is caused by those numerous myriad causes we've already gone over. This being normal aging. And I want to point out, normal aging is normal decline. You are not going to be as sharp and crisp at age 80 as you were at 38. So we have to really tease out what's normal and abnormal. prevention. Excellent questions. And I want to stress a couple things on this slide as we go over, because these are hugely beneficial, things that we can do now, today, tomorrow. And that includes taking care of your blood pressure, 120 over 80 or lower, depending on what your cardiologist and internist say, of course. People say, well, how low is too low? It's interesting you ask that, because each year they post new guidelines. We call it J&C guidelines. They were at J&C 7 and then J&C 8. Comes out with new blood pressure recommendations, and they're all lower and lower each year. Why is that? That's because higher blood pressures are hard on those little tiny blood vessels in the brain. In other words, your cholesterol numbers, your blood pressure numbers count. Eating a good, healthy diet with less processed foods, whole foods, very beneficial. But this is something I really want to stress, and that is jogging your mind. And they don't mean going out necessarily and exercising in the sense of running a marathon. We don't want anybody in here to be a weekend warrior, but what I would admonish all of you to do is find 30 minutes a day, 5 days a week to walk. Simple, easy, approachable options that I can cite scientific evidence that frankly piles up with a greater height each year for the benefit it will provide for your brain. People say, why exercise, Dr. Thornton? Shouldn't I go out and learn Japanese and play the piano? And absolutely, do those things, but first and foremost, exercise. And again, back to that Nobel Prize I'd like to win, and I can tell you why that worked, I would have earned one. And there's lots of smarter people than me out actively working on telling us why that matters. If I could draw a big red circle around this, I would do it in your mind. And that is, lead with this. What is something I can do today? You don't need to set a land speed record. All you need to do is just walk 30 minutes a day, 5 days a week to improve benefit. And it'll be like putting money in the bank. You're going to get back a lot more than you put in over the years. Just do it daily. Work your body. Stay connected. We don't want you sitting around on your couch watching Alex Trebek all day. That's not going to help your brain. You might learn some Jeopardy, but it's not going to keep you from getting Alzheimer's disease. Everyone here is involved with family, community. Coming here, taking time out of your busy schedule is beneficial. Get out of your home and connect. Volunteer. Even stay employed. People say, gosh, what do you mean, Dr. Thornton? I retired at 65, I worked hard. Absolutely, but maybe a part-time job wouldn't be a bad thing. I feel, with my experience with research, that just staying involved, staying active. If you're a Walmart greeter, excellent. It's whatever you can do to get you out of the house some, because we know that's beneficial. That couch will grab you and not let you go, and that will increase your risk of Alzheimer's disease. You know, I tell my kids, protect your head, wear your bike helmet. I tell my son, don't head the soccer ball. Would you grab your iPhone with a 70-mile-an-hour soccer ball coming at it and bang it across the field? Absolutely not. My son said, Dad, I love my iPhone. I would never do that. And I said, well, don't do it to your brain either. And I think he's got good coaches, but I just said, don't treat your brain badly. Don't tackle with your head. Things we can all tell our grandkids and kids, right? Very important. And you know what? Coaches are getting a lot better at that. Have a good attitude. You know, there's something to be said for being positive. Do bad things happen in the world every day? Absolutely. They always have. Be positive. Look for ways to help others. Stay connected. Be sociable. Eat healthy. Read. Enjoy life. Stay interested. And exercise. Absolutely huge. I don't know why that matters to the extent that it does, but I want to again just reiterate it. So we really have a lot of ways to manage symptoms, and we've got some ways to actually slow the disease down pharmacologically, in other words, with medication, and that includes medicines that have a humble benefit you can talk to your primary care physician about if you've been diagnosed with Alzheimer's disease. All right, I'm trying to make sure I'm remaining on schedule and I give Stephanie her due time. So we're kind of approaching the end of my talk now, but I saved these for last because they're modest. They are not cures. They have shown data at 1 or 2 years to keep you a little higher cognitively than you would be off of it. But are they a cure? Absolutely not. So just want to make sure you know pharmacy and medicines are beneficial, but by no means a cure. This just is a complicated slide that shows how the medicine works by increasing acetylcholine as nerve cells talk to each other. Some really busy slides I'm going to kind of gloss over. And then, again, for my professional colleagues, this is kind of how it works. It increases a molecule called NMDA, which is an important brain transmitter. And it's been shown to help, again, modest. I want you to take home that point. Modest benefit, not a cure. Would you take it if your doctor asked you? I would, absolutely. They do help, and they are inexpensive, and they don't cause a tremendous amount of side effects. So medicines can be beneficial. And this just talks about how they work. What else does Alzheimer's do? Well, later in the disease process, it can cause issues with symptoms that are very hard for family members to deal with. Agitation, delusions, you're taking my money, you are hiding my things around the house. I hear these things all the time. They're so stereotypically common. And they're devastating to family members who would never hide somebody's things or steal their money. To hear that from somebody they have known for 50 years. So there are lots of things that we start to see, and frankly, we try to manage those non-pharmacologically as well. In other words, without medicine. Antidepressants here I want to mention as I approach the end of my talk. We have found, and this is between now and when I last gave this talk a couple years ago, new research has shown untreated depression is a significant risk factor for earlier conversion to Alzheimer's disease. If you feel like you have depression, ignoring it, not taking medicine is not just good for your quality of life now, but it increases the risk of developing Alzheimer's disease. Depression is very common in Alzheimer's disease in caregivers and the patient. I treat it. And that's a way we can improve the progression of Alzheimer's disease. Delusions, you name it, lots of different things can happen. And we try to manage those with redirecting patients, with changing the subject, in other words, and not by putting them on high-potency antipsychotic medications. What's the latest in research? So research involves stopping this process along this cascade, and people are working at each one of these links right now. What we do know is that immunizations and things like that can help. They can also cause horrible brain inflammation, which can be deadly. We found that out the hard way over the last 10 years or so with lots of research that's going on. So there's just various different techniques that, can you imagine getting a vaccine at age 30 to prevent you from getting Alzheimer's disease at age 80? Those are things they're working on right now. Is it close? No. But what I'd like to summarize now at the end of my talk is that age and environment and genes play a role. Amyloid accumulates, which causes brain cell death. It starts many years before you show your first symptom, and treatments are available. We just don't have a cure, and here is yet. Very important. With that, I want to close and turn the stage over to Stephanie and just thank everyone for the pleasure and the privilege of being here today and visiting with you. We will have question and answer time momentarily.
Thank you, Dr. Thornton. And as he said, he has graciously agreed to stay, and we'll have questions after we hear from Stephanie Ramirez, who is a speech and language pathologist at North Kansas City Hospital. And she's going to talk about different ways in which people with dementia or Alzheimer's can benefit from speech therapy. And she's also going to share information on a new support program that we have for people living with Alzheimer's or dementia. And we're very proud that it's the first program of its kind in the Northland. So please join me in welcoming Stephanie Ramirez.
All right, thank you for having me. As Peggy said, my name's Stephanie Ramirez. I work as an outpatient speech-language pathologist at North Kansas City Hospital. A little background about me: I actually started at the hospital over 10 years ago as a student. I started my career at a nursing home and rehab center. Working in that field and that population really sparked my interest in this area. And then when I returned to North Kansas City Hospital to work full-time in our outpatient program, I really saw the need to jumpstart our outreach to this community and to expand the services that we offer for these patients. And it's really exciting because in the past 10 years, there's been a lot of research done, a lot of advancements and evidence-based practice in the treatment that we provide to our patients. My grandmother also passed away from Alzheimer's disease on Mother's Day of this year, so I also have a very personal connection and passion for this field. And I want to start with a quote. Those who have dementia may have a brain that works much differently than ours, but if we link our hands together, we can overcome anything. And I really think that's important to keep in mind. This is a team approach. And you know, as a speech-language pathologist, I work with the patients, but I also work with their caregivers, their loved ones, to offer my support and insight. And I work with patients before they even get the diagnosis, all the way through potentially early, middle, and late stages of the disease. So together, we can do our best to give our patients a good quality of life. I want to start by bringing up this graphic. This is from the Alzheimer's Association website, and these are their 6 components to living well with dementia. And for those of you who have not checked out alz.org, it's got a lot of really good information. That's the Alzheimer's Association website. For those who are newly diagnosed or those who have already been diagnosed in the past. So I want to highlight the top 2 components to this living well: challenge yourself and stay connected. So first and foremost, challenging yourself. We can do that with our speech therapy program. And why is that important? So what we like to focus on is using what the patient has more effectively and efficiently. We do this through strategy training, through exercises, and I'm going to get into a little bit more of that in a few moments. We also work with the patients and their family on planning for the future, modifying their home environments so they can stay home longer, live safely, as independently as possible, planning for the next level of care, when that is appropriate, when that is indicated, and providing the resources that will help guide the family and the patient to make an informed decision. We also talk about stress management and support. I find that simply getting some education and shedding some light on this disease can often help manage the anxiety that comes along with receiving this diagnosis. I think we're working towards reducing the stigma that comes along with this disease, and I think that's very, very important. And of course, when a patient or a caregiver is feeling overwhelmed, we can often help make referrals and recommendations for counseling services and things of that nature. And ultimately, our goal is for our patients to feel both mentally and physically better when they're done. And that includes all of the things that come along with the progression of the disease. I like to say, as speech therapists, we work everything from the neck up. So that includes memory, speech and language, but it also includes swallowing and eating, which can be affected later on in the disease as well. So we really cover the whole spectrum. So when you come in for an evaluation, we get the referral from the neurologist or a primary doctor to evaluate the patient. And as Dr. Thornton said, it's really a plethora of information that we have to dig through and look through to determine our course of treatment. So we look at medical history, review medical records, possible brain scans, but most importantly, we discuss, the patient's symptoms and complaints. What is it that's affecting their daily life? Where could we make the biggest impact? And we want to set goals that are meaningful and achievable. No two people experience Alzheimer's disease the same way. No disease progresses in the same way. So we have to really look at where you are right now and what we can do to help. And we do that by looking at standardized cognitive testing as well, so we can really measure, okay, here's where you are today, and then we have a baseline for looking back in the future. Treatment is 3 parts. So first is the restorative treatment. So this is stimulation, memory exercises, strategies, attention exercises, safety and problem-solving scenarios, word-finding exercises. Those are all things that we can do to help stimulate your brain. Back in 2007, there was a study that was done that showed that the effects of cognitive training weren't lasting. However, in recent years, and specifically back in 2018, there was a systematic review of various studies that showed that cognitive intervention was better at slowing down the disease progression, improving function, as compared to usual care. And I find that, with my patients, if we can look at it from a pharmacological standpoint, what has the neurologist, the doctor recommended, how can we support that and really exercise the brain? The second part of therapy is adaptive. How can we compensate for the parts of the brain or the functioning that's not where we'd like it to be? So we do this with various strategy training. So we can use a memory notebook. We encourage using a planner, a calendar to stay organized and oriented, doing journaling, how you set up your home environment. So for example, keeping things you use together in the same place, labeling drawers and cabinets throughout the house. Just being very organized and mindful about how you're setting up the home. We talk about safety strategies, so ways, again, that somebody can live independently or stay home as long as possible without having to go to that next level of care. And then we talk about self-cueing strategies, so visual aids throughout the house. Space retrieval training is one area where we've seen some really good research. So positive learning, if you can space out recall and retrieval a little bit longer each time, then the person's more likely to recall it for longer periods, and you can kind of train those things that are important to them. Our final component of therapy, which I find to be equally important, is looking from the caregiver's perspective and working with them. How can we help make sure that they're taking care of themselves? Because you're not going to do anyone any good if you don't take care of yourself first. How they can more effectively communicate with their loved one, meeting them where they are in time as opposed to trying to argue with them. Again, how to set up the environment to make things easier on both of them. And then stimulation activities. There was a systematic review in 2007 that showed that caregiver-administered cognitive stimulation was beneficial with maintaining both cognitive and behavioral functions. So some of those negative behaviors that you might see in the later years can really be addressed. And so I encourage always family to come to our therapy sessions because they're getting training to continue the therapy long after the patient is done working with me. And then planning. So we want to make sure we have good supports in place and a plan for what the next step is as the disease progresses. plan various activities, and really tackle this, like I said, as a team. So that brings me to our next section, which is staying connected, and Dr. Thornton discussed this as well, how important it is to maintain those social connections. A lot of times when people find that their memory isn't as good as it once was, they start to withdraw from doing the things that they once loved to do. And so we wanted at North Kansas City Hospital to find a way to connect people together, to offer support to patients with this disease and their caregivers, have something they could do together. And so we've started this Alzheimer's support cognitive learning series. And this is in the Northland. It is at our Zona Rosa Wellness Corner location. We'll talk a little bit more about that specifically in a moment. But it's accessible, it's really fun, we have a good time, it's always free. And every month we try to host at least one activity, education, social, physical activity, or art. So every month we have something going on that will connect people together. So some of our past themes are education sessions. So again, something where people can come and get more information. The art program, we've done painting, screen printing, sculpting, dancing. And with our social group, we've done a Super Bowl party, we've done trivia nights, board games. So it's really fun for everybody. And like I tell people, you do not have to have an Alzheimer's diagnosis to come. We're not checking those at the door. Anybody who wants to come, who has an interest, can participate. And we really encourage family to come together because that's what this is about. Meeting other people and connecting with your loved ones. In 2020, Shanna and I have been hard at work coming up with some fun themes. So a little preview, we have Take Me Out to the Ball Game, which we're partnering with the Negro Leagues Baseball Museum. We are getting a representative from the Mid-Continent Public Library who's going to come and talk to us about being a bookworm. We're going to be doing an ice cream social, National Pet Month with the KC Pet Project, and then as always, we'll have an ongoing relationship with the Nelson Atkins Museum of Art to do our art programming, the dancing and physical music activities, and then always education. And I will say, because I've had this before, you do not have to have any art experience or talent to participate, trust me. If they can get me to paint well, they can get anyone to paint well. So they do an awesome job, and everyone comes home with a beautiful piece of art that you can treasure truly for years to come. So our upcoming programs, we have a game day, November 18th, where we're going to do some trivia and board games and fun things like that. And then December 9th is our next art program with the Nelson Atkins, and they like to surprise us with some of the themes of what they teach. So that is a surprise. So you'll have to sign up and come to see what you get to do. But Shannon has a sign-up sheet where you can, as you leave at the table, sign up with your email if you want more information on these. Or you can go to nkch.org/healthed or under the events tab on the North Kansas City Hospital website. That will have all of them listed. And like I said, they're every month. The dates do vary, but programs are typically from 4 to 5 p.m. in the afternoon, so not too late as these cold days get shorter. And they're all at the Wellness Corner at Zona Rosa, so someplace that's a lot easier for people to get to if they're coming from the Northland. I just wanted to include some resources. If you're wanting more information or you have questions, obviously, North Kansas City Hospital, we love to be a resource to each and every one of you. Some of these other websites are very helpful and informative as well, and I would really encourage you to also look into the Alzheimer's Association. They have a 24-hour helpline that is available to anyone, and they are available 24 hours a day. So, and then if anyone has any further questions, I'd just like to include my contact information so you if you don't have time to ask your question today, or if you aren't comfortable asking in front of the group, I completely understand, so you can contact me at my email there. All right.
Well, let's thank Stephanie. And then we'll invite Dr. Thornton back up to the front with his microphone, and Stephanie, you can use this one, and we have time for a few questions. And I will let Dr. Thornton recognize people by pointing in their general direction. That happened to do a lot of things. Maybe I should, yeah. And we'll repeat the question after it's asked so that everybody can hear it.
I'll just kind of move across the room, and hopefully we'll get to a lot of questions. So, yes, ma'am.
I've had thyroid disease since I was 18 years old. I've been on medication and it's been under control, but is that something I need to think about?
The question is, I have a history of thyroid disease. Does that have bearing on the diagnosis of Alzheimer's disease? And the answer is yes. Ensuring that your thyroid is adequately treated with your medication is very important, and that's one of the things that we usually check at a visit. We'll usually check a thyroid stimulating hormone level to make sure that the treatment is working and keeping your thyroid in good shape, because if it's not, that can cause memory problems. Yes, sir.
You had a chart on alcohol, and then what you're thinking on soda drinks as far as
Alcohol is a less is more. You know, there's some evidence that shows alcohol in moderation, like most things, is beneficial. People say, well, what does that mean? And that means less than 1 or 2 drinks, I would say a couple times a week. Moderate alcohol consumption has been linked to a decreased, mild to moderate, 1 to 2 drinks, has been shown to decrease alcohol or memory problems. Anything above that, it is a rapid decline, and I really just strongly don't recommend alcohol, especially if there's a family history of alcoholism or anything like that. Just a little bit doesn't hurt you.
soda drinks?
Soda.
Soda drinks like Diet Coke?
There's no evidence that they have any bearing, but I don't think they're good for your sugar metabolism, and I wouldn't recommend them.
Caffeine?
Caffeine has shown itself to be somewhat beneficial in certain disease states like Parkinson's, which is not unlike Alzheimer's in that it is a neurodegenerative condition. In general, I advocate for caffeine unless you've got migraines or bad headaches, in which case probably caffeine is not really a trend. Yes, sir.
Earlier you mentioned the environment as issue that cause Alzheimer's. So what is in the environment that causes it?
That's an excellent question, and we don't know. But I would broaden environment to be your activity level, your diet. Certainly there's some hazardous chemicals we don't want you around, and frankly there's nothing toxic in our environment, whether it's, you know, we're always hearing these scary things about mold or pesticides, or I'm going to get cancer from my Roundup. You know, there's so many frightening things in the news, and those are all newsworthy, but clinically they're just not really relevant. I would say diet, exercise. You've heard that platitude from neurologists and every other doctor you've ever been to. I just got to bring it home again. That part of your environment is very important. What you do for a living, how active you are. Being sedentary is not good.
So to follow that up, is there a cause that is leading this to be more prevalent in this area you mentioned, the environment?
You know, really, I don't think that there is more here than there is elsewhere. To the extent that there's more diabetes, high blood pressure, heart disease, and sedentary people, there will be more Alzheimer's disease. But I don't think we're unique in the Midwest. I think all parts of the country have issues with that. Yes, ma'am.
I have heard on television there's a new drug out that they've had good success with Alzheimer's, but the FDA hasn't approved it yet. It's supposed to be out after the first of the year. They're supposed to approve it. Do you know anything about that?
Be very careful. Sometimes even the Star, the good old Kansas City Star, will have if you read up in the corner, it will say paid advertisement. And you'll look at this and it looks like, it's got a byline and you're thinking, hang on a second, this looks like something a staff reporter wrote. When in reality it's a paid advertisement. I can't speak directly to what that is. If you ever want to if you have it here, I'd love to look at it after we're done. But be very cautious with what the various talking heads on TV are pontificating about. Dr. Oz, for example, he gets paid lots of money to advocate for dietary supplements, many of which have not shown a lot of efficacy scientifically. So I'll keep going back across the room. Yes, ma'am.
Are there any medications that actually contribute to Alzheimer's?
Let me first answer that question in its reverse. And that is, there's a lot of medicines that in the press have been purported to cause memory problems. Statins. Absolutely no evidence of memory problems. Period. Many of us are on statins. I cannot speak highly enough for them. They are wonderful medicines if you can tolerate them and your muscles don't hurt. Will they cause you to get Alzheimer's disease? Absolutely not. You just don't get put in the newspaper for saying statins are good for you. You got to come out with something like statins are going to cause Alzheimer's disease, and then you'll get press. But statins are safe and effective, as is omeprazole and other things we all take. I have no evidence any of those contribute to Alzheimer's disease. So I really don't feel like there's a lot of good evidence. Let me say there is some recent evidence out within the last 6 to 8 weeks that I'm aware of from overseas documenting anticholinergic medicines. Those are medicines for like Parkinson's disease and GI issues. I'll name a few. Amitriptyline or Elavil would be one. Artane or triacylphenidil for Parkinson's would be another. And they have been shown to cause problems with memory. And actually they do the opposite of what Aricept does, which is one of the medicines up there. Benadryl. A lot of us have taken or do take Benadryl or diphenhydramine, which is the active ingredient in the PM medicines. It has a little bit of anticholinergic activity to it, but I want to just go ahead and say in this research, which I've looked over personally, Benadryl is not singled out in any way. In fact, there's no data that Benadryl is going to cause you to have memory problems. Yes, ma'am.
Yes, two parts. Is this year's flu shot safe for an Alzheimer's patient to take? And second, in the progression of Alzheimer's, is there some point where you would stop prescribing the Menda and the Aricept?
Excellent question. The first question was, is a flu shot this year safe with an Alzheimer's disease patient? Absolutely. You need your flu shot. Influenza is deadly, is preventable, and it will not harm any neurologic disease state in a major way that I'm aware of, and that includes Guillain-Barré, which is always reported in the literature to be a concern with flu shots. If I had Guillain-Barré or its chronic equivalent, CIDP, I would get the flu shot every single year, period. Big believer in vaccines, and I know they get a lot of bad press too. Don't get your medical advice from the newspaper. I've never seen anything that would convince me not to vaccinate my children or my, say, father who had Alzheimer's disease. And the second part of the question was?
Is there any point in the progression?
I continue it indefinitely until hospice or something like that is instituted down the road, and here's why. There's no stark line as to when it stops being effective. And I've seen it, the opposite of that be the case where we've stopped it and somebody's had a little more precipitous decline. If it's not doing any harm and there's some theoretical benefit, I would say I would opt for ongoing continuation unless it's causing difficulty with diet or maybe hospice or something like that is instituted and we're not putting pills down somebody's throat who's in hospice. Excellent question. Yes, sir.
Yes, Irbesartan has, I understand, been recalled. Is it is there anything that...
No, I use Roundup. I've credible evidence. There's a jury verdict. You can weigh that as you would as to whether or not you would say that, Monsanto has any kind of culpability with causing people to get a certain kind of blood cancer. Has a pesticide ever been linked to Alzheimer's disease? No. Excellent question. There's some data out there that would indicate old, I'm talking 1950s pesticides, some of you in this room may remember, depending on if you ever farmed, how remotely ago that was. Paraquat was one, very common. Sir?
Chloroquine.
Yeah. Some evidence that it can contribute to Parkinson's disease, although it's by no means a connection. Sir? I believe Agent Orange causes neurologic symptoms. The degree to which it does so is not clear and has been covered up to some degree over the years, but I think that Agent Orange is not something that should ever be used anymore, and thankfully we haven't used it for decades. But I think there's some credible evidence that neurologic disease has been linked to that combination of, as you know, Agent Orange is a combination of defoliants. Yes, sir.
Cannabis in the oil form or any other form has not been addressed.
Excellent question, and the question was, is cannabis or marijuana useful in the setting of Alzheimer's disease? And my answer to that now is emphatically no. And that is because I don't have any scientific credible evidence to stand on. It has been shown to maybe mitigate some symptoms. Is it something I would consider ever using in my practice as a mainstay? No. And I can promise you, if I had any evidence that it was beneficial and not causing harm, I would advocate for it, because this is not a disease state where we have powerful weapons, and any weapon, albeit humble, would be very welcome. So I don't feel that at this point, despite what these new ballot measures have passed, saying I don't have a lot of evidence that it's going to help my patients, and I don't have, and that's what really matters to me. Is it helpful? Excellent.
I think we have time for one last question.
Stephanie, are your treatments typically covered under insurance?
Yes, so you can get a referral from any doctor, and then Medicare, private insurance typically covers it. Sometimes there is a visit cap or a deductible. We have a person who specializes in insurance in our office who will check to make sure everything is covered before anybody comes in. But in my experience, it's always been covered.
Terrific. Is that typically once a week? Once
So
a month?
depending on the severity and what our goals are, usually 1 to 2 times a week for an hour each time, and then I will give homework for things to do at home in between sessions, and then typically 8 to 10 weeks to really get a program, a routine going that then can be continued after therapy's over.